All this is Dr. Mubin Sayed from Drbeen.com. Welcome to one more show. So hopefully everybody is doing good. You had a great long weekend. I totally enjoyed it. I'm going to tell you something funny about my weekend. So on Friday, I thought, you know what? We have Friday, Saturday, Sunday, Monday off. So why not I sleep on Friday? So I have a sleeping pill and I took that and I wanted to sleep and I just could not sleep. So the Friday's day was like half asleep, half awake, sitting on my bed, thinking what is happening. And then Saturday, I had Saturday night, so the night between Saturday and Sunday, I had a presentation for Pakistan Medical Association about COVID and the latest, researches and studies and management techniques that people are using. So Saturday's day, I prepared that. If you like, with the disclaimer that this is not a medical advice, I could share that tomorrow with everyone here. This was more of a, what are the things to do when managing COVID patient based on various pathologies that occur, and these drugs modulate those. So I had that presentation. So Saturday was spent most of it preparing for that presentation. Then at night, I presented it. It was 11 my time night. It was 11 a.m. of Sunday there. And we went from 11 till 2 o'clock. It was 3 hours long presentation. It was so much fun. There was an initial part of the presentation, then there were question and answers. And I was actually blown away by the success of management. Although Pakistan is once again in lockdown, but they are 220 million people, almost 2/3 of the US population. But their total cases, I think, are 1 million, and total number of deaths are 10 or 20,000 or lesser. So of course, there is something that they're doing right. Or maybe they're just not reporting. I think that they are reporting. But anyways, so it was interesting for me to see, for example, one of the doctors had made this comment that they start steroid use right from the beginning. And you know that I am very, very concerned about starting it in the beginning, because there is a study that says that the coronaviruses are difficult to clear in the presence of steroids compared to other viruses. So, but they said we start, for example, the steroid early on. In addition to that, there were so many of the doctors who said we use ivermectin. Ivermectin is standard for them. And so they start them early on. And it was interesting. There were doctors from the college I studied from, King Edward. And Mayo Hospital is Pakistan's one of the largest hospital. I think it is 17 or 1800 beds hospital. I did my residency in there. So there were doctors from Mayo Hospital who were saying that this is how we are managing. So that was very interesting. So Saturday and Saturday night was mostly preparing and presenting. Sunday, then I think we went out to an escape room. The escape room was here nearby in San Jose. It was called Insane Asylum. And of course, we could not beat it. But according to the escape room folks, we were almost at the last clue when the time was up. So that is what happened. Yesterday was more of a thinking that, all right, the days off are finished. So that was my long weekend. How was it for you? Okay, so there were some questions about this vaccine that I saw while I was getting out of the live talk. Let me very quickly see if I can remember those questions and answer them. So there were questions like, one question was, forgot. Let's see if those questions are here. Janet Masley says, Pakistan hospital, are they administering black seed oil? Many are, not all. So even in Pakistan, I would say there is three groups of doctors. Those who very strictly follow FDA, CDC, WHO. They will not do anything that FDA did not say, American FDA or CDC did not say. Then there is another group that is in the hospitals, just like here as well in the US, who would stay within the bounds of the hospital protocols, and they would do as the protocol is established. And then there is a third group who may be general practitioners or who may be out practicing privately, maybe even specialists, and they would look at the latest discussions, and they would then try to use those medicines as well. So we see the similar pattern everywhere. I think the difference is in the percentage of how many doctors are trying new things versus not. Okay, so there were some very good questions which just So Janet says, not medical, not even from us here, doctors, like ever. Yes. Joyce says that I saw someone mentioned melatonin. What is the story about melatonin for COVID? So Joyce, I did a discussion about a year ago about how melatonin works. And the FLCCC, of course, prescribes melatonin as a regular part of their protocol. Melatonin's basic function, there are two main functions of melatonin. One is it helps with the sleep. So that is just a general thing, good thing, that a person who may be exposed to COVID is able to take good, restful sleep. The other one is that melatonin can help the mitochondria in our cells. It enters the mitochondria, and inside the mitochondria, in the inflammatory state, certain enzymes are not functioning correctly, which causes the cell to be in more of a oxygen consumption state, which is not the best. Most of the oxygen production and consumption, or ATP production, shifts to the cytoplasm, but it is not anaerobic respiration. It is still aerobic respiration, but it is mostly happening in the cytoplasm. The result of that is that the ATP generation is less, oxygen consumption is not correct, which then leads to the hypoxia that we see, plus the issues that we see with the cell in terms of inflammation. Melatonin can come in according to the mechanism. And I have done these discussions. According to the mechanism, what happens is that melatonin enters the mitochondria. Over there, it goes and reverses the enzyme's phosphorylation or inactivation, which then causes mitochondria to start working correctly, produce good amount of oxygen, reduce inflammatory proteins, which in turn stabilizes the cell. And as that cell starts functioning better, it would produce interferons as well, and it would make the neighboring cells better as well. So melatonin is not only helpful for resting, but it is also helpful for better oxygen utilization and reduction in inflammation. And these are important things. Better oxygen utilization is important for SARS-CoV-2 because SARS-CoV-2 causes so much damage to the oxygen utilization processes. Genesis Light says, would steroid applied at early stage of COVID would encourage viral replication due to immune system suppression? So Janet, this is where I had discussed a study. I think this is also 1 year ago. There is a study where what they did was they studied various viruses and their clearance by our immune system in the presence of steroids. And they noted, or they observed, that in the presence of steroid, coronavirus clearance from the respiratory tract reduces. The clearance reduces. That means coronavirus lasts longer in the respiratory tract in the presence of steroid. So there is one study. I have always looked at that study and said, this means we should not use steroids early on, because that would allow the virus, the SARS-CoV-2, to continue to multiply and stick in the respiratory system for a longer period of time. However, many doctors, even that day in the presentation, they simply say, we started very early. The general practitioners in Pakistan, this is their standard regime to use vitamin D, steroid right from the beginning, azithromycin, ivermectin, quercetin and zinc, Fexet, anti-allergy or antihistamine, statin. This is their standard structure, formula, protocol that they have landed on. So majority of the general practitioners who are sitting in various streets and they are managing patients, this is what they're doing. Soma says, cannot plasmid cause infection? What is its adverse or disadvantage over adeno? Very interesting question. So according to that company statement, they said, in case of adenovirus, we know that there are adenovirus related immune responses, which they're correct. Adenovirus is a virus, and our immune system is going to respond to that virus as well. And they said that this plasmid is not a similar thing as an adenovirus. So the adenovirus type immune response does not happen with the plasmid. So that is one. The second part that you're asking, that will the plasmid cause infection? So no, it will not, because on the plasmid, the gene that is present on the plasmid, on this little donut, the circular thing, is only the gene for the spike protein. And the plasmid itself is non-replicating. So that means the plasmid, if we injected 1,000 plasmids, then the cell would only have 1,000 plasmids. They will not become 2,000 or 4,000 or 10,000. And because the plasmid has a spike protein gene to produce spike proteins, it will only produce spike proteins and not the whole virus. So neither will it infect to cause SARS-CoV-2 production, nor will it infect to cause more production of its own self. So it is a non-replicating, non-integrating plasmid. Very interesting technology. So Kevin Braza says, Dr. Mean, would you say that if we wear N95 mask, we are still as protected from Delta and public as with British variant? So N95 is supposed to protect to 95% of the protection from 95% of the viruses and bacteria or pathogens. So it is one of the best protection available in masks. And I had seen this question once before as well, that somehow the Delta and the original Wuhan have a difference in protection from the mask. And that is not the correct way to see it. Let's say there are some people who say masks do not work. There are some, including me, who say masks work. If masks work, then the Delta or the Wuhan virus, the masks will work similarly, correctly, because the virus's own size has not changed. And that very tiny change in the spike protein is not sufficient for the virus to beat the mask. And this idea that the virus is smaller than the smaller size in the mask, we've done this discussion before. Mask is not only holes, smaller holes, it is also electromagnetic forces on it as well. So it is like picking up the virus and just sticking it to the mask, because there are electrical forces in the mask as well, because of the thread, the material in there. Now, does that mean that normal, common, day-to-day cloth used as a mask are going to be as effective as, N95? Not at all. But they are going to help as well. If masks don't work, so let's go with this idea that masks don't work. If they don't work, then that means they will not work on Wuhan and they will not work on Delta as well. So masks are going to stay uniform. The virus has not made any changes in it to either become more vulnerable to mask or to become more less vulnerable to the mask. Having said that, N95 are the best type, so they would help. Adina says, is black seed oil contraindicated with ivermectin? No, so not from a mechanism point of view. Black seed oil is anti-inflammatory. Ivermectin has one of the function is anti-inflammatory as well. So no, but of course, I cannot offer this advice to any single person. Everyone has to talk with their doctor and figure out what is right for them. But from a mechanism point of view, these don't cause any issues for each other. Elizabeth says, how do I get colchicine, please? Recommended by Dr. Mello for pre and post vaccine. So I don't know if colchicine, at least in the US, is as widely used as ivermectin has been. And at the end of the day, your doctor will have to decide what are they going to prescribe or not. But again, this is in the hands of the doctor who's prescribing. Learn Verilog says, hey doctor, how long is the half-life of these plasmids in the body? No idea. I do not know yet that once this plasmid is in the DNA, how long after it will have been degraded. Ideally, it should be 2-3 days that it has been DNases destroy it. But because I have not read it somewhere, I cannot say it with assurance. Doug Gross, Westfield says, Doug Gross, I hope. Okay, so let's see. Let's go to Doug's question. Doug says, I tried 70 milligram, no joy. 70 milligram of what? Iron Bubble says, Dr. Bean's chat is kind of a pandemic therapy. Well, they're trying to punish me for these chats. We'll see what happens. They say no good deed goes unpunished. Let's see. Doug says, Doug, I'm still scrolling through the... So trying to convince some family members to get vaccinated. Look, this is actually very, very important, especially given the way Delta is now pressing on. It is very important to get the vaccine. And I think I should do a discussion about all these myths. I have done these discussions partially in various videos for myths like vaccine would change our DNA, or the vaccine would cause spike proteins forever to be made, or our cells will become modified, or vaccines would kill us after 2-3 years, or they would cause, let's say, infertility, or they would cause clotting, or they do cause clotting, but smaller number, and we can understand how to fix that. Or there are many such myths. So maybe I should just pick up those and in one session just go through them. Comparing vaccinated to someone who will get an infection. Infection will produce immunity too, but the question is there a guarantee that the person would survive? And then this is actually an incorrect thing to say vaccinated has more number of deaths compared to unvaccinated. This is not a correct data point. So we'll have to. Okay, so here, Doug Gross says, what does it mean if melatonin doesn't help sleep, even at high doses? So I have never heard of this. Here is why. We release melatonin in the evening to make us go to sleep. So if you have your normal natural sleep that you can get, majority of that is triggered or helped by melatonin. That means newer melatonin should also help. The question is it getting absorbed correctly? Is it entering the blood system to be able to do its function? Otherwise, melatonin is going to act. That's a very interesting situation though. Cabs says, Dr. Bean, one more melatonin question. I've been experiencing anxiety and irritability, been on melatonin for 1 month, 5 milligram. So I'm always very careful. I have to be even more careful to say I can't offer advice in general online and in specific to any single person. So it's not an advice, but talk with your doctor and discuss. Remember when we talked with Dr. Paul Marek, his answer to us, not anxiety, but melatonin dose causing issues, was to change the dose, to reduce it to half, and then see how does it look, and then change it again towards higher. So again, without trying to give you an advice, dose adjustments for melatonin effect may be useful. So Adam says, melatonin at 5 milligrams gave me night terrors. Experimented with it many times. Gal at health food store ate the same thing, happened to her. So when I take melatonin, 5 milligram or 6 milligram, I get such vivid dreams that I do not even know that this is actually a dream. It is just so real and so terrifying. It is terrifying. So I actually don't take melatonin unless I have to. For example, this weekend on Sunday, I think it was Saturday or Sunday, I started having cold. And the symptoms of cold and my nose, you could probably still hear some nasally sound from me. So my nose got congested and my throat started hurting. And I said, oh God, I got COVID. So for the listeners who are new, I have gotten my vaccine. I've gotten both Moderna shots. And so that was, I think, in May. So it's not too far back either. But anyways, I thought, all right, I got COVID. So I rushed to get my ivermectin. And the next day I was so much better. So I was like this. But a few hours later, I started developing the same sore throat and runny nose. And I went in and I took melatonin again. And then I'm here. This is what it is. So these are the kind of times when I want to tend to take melatonin, but it gives me such nightmares. And when we spoke with Dr. Paul Marek, he had said just reduce the dose to a point where it does not give you nightmares, and then see from there you can increase or not. So you have to experiment. That's how he had responded to this kind of a question. So again, not an advice to you. Yep, Rico USA says, I learned that bats are carriers of COVID-19 and have the highest composition of melatonin in animal kingdom. Yeah, so Dr. Paul Marek says that all the time as well, that, hey, the bats do not get this. So Nancy has a very interesting question. If I want to know if I had a natural infection before getting the vaccine, would the nucleocapsid antibody test likely be positive 1 year later? I can't say. The studies have shown that the antibodies produced for SARS-CoV-2 starts waning anywhere between 3 to 6 months, and then their levels go down. Now, will the antibodies still be high enough to be detectable as above threshold detection after a year? I do not know. I think it will not be. Instead, the maybe T-detect kind of a cell test that detects the memory cells, that may be more indicative compared to antibody. I think antibodies will have waned, but that's my thought. Soma and Srijoy says, does the antibody produced against the spike protein, only binding antibody, Does it mainly target receptor binding domain to avoid binding antibodies? Is binding antibodies from infection useful? So good question. And the answer is actually, the answer will become don't know. And here is why. Let me explain. So let's say we have given a vaccine or infection, and here is the spike protein produced. And let's say this is the receptor binding domain here. This is the receptor binding domain. Now, I think there are, what, more than 1,200 amino acids? I forgot the exact number, but there is a hundreds of amino acids that are present that are making this spike protein. And we can identify anywhere from 7 to 23 based on T cell or B cell receptor. For example, B cells would go from 7 to 12 or 13, and T cell can go anywhere from 11 to 22, 23. So we can identify a pattern as small as 7 to 12 amino acids. And then based on that, we can create antibodies. Right? Now, all antibodies are binding antibodies. Binding simply means that the antibody would come and attach to where it sees the antigen or that pattern. Neutralizing antibodies, from a definition point of view, is the following. Imagine if an antibody is stuck at the receptor binding domain, and now it will interfere with this antibody from attaching to the SARS-CoV-2, not SARS-CoV-2, to the ACE2 enzyme on our cells. If this happens, then this antibody is a neutralizing antibody. But at the end of the day, all of them are binding. But from a definition point of view, when they say binding, what they mean is an antibody that is bound to a place on the spike protein that does not, where when it is bound, it will not interfere with the binding of the spike protein to the ACE2. This is a very common myth as well, that if we have a binding antibody, then somehow the cell is not going to, the virus is still going to be able to infect, and this would cause ADE and stuff like that. That's not true. I have done this discussion many times, that even if this is a binding antibody, every antibody, binding or neutralizing, have an FC portion, fraction constant, this part. This part can attach with the macrophages, it can attach with the natural killer cells, it can attach with the other immune cells. This can cause complement activation, and there is so much more of the immune system responses that can occur when the antibodies are bound to an antigen. For example, if you read the phagos, what is this called? There is a specific term. So this is my problem, that when I'm speaking all those general standard terms, I don't do lateral jumps on them. There is a term for whenever we coat an antigen with the antibody or with the complement, it becomes, that thing becomes easy for our macrophages to eat it up. So binding antibodies actually make that antigen easy for the macrophages to eat it up and destroy it. So binding is not a bad thing. It is important. So now if I go back to your question, the antibody produced against a spike protein, is that only antibody binding? No. So there are going to be some that may be neutralizing, depends where they attach to the spike protein. Does it mainly target receptor binding domain? Again, don't know. Everybody's antibody responses, the type of antibodies they would produce are going to be different. So some of them will be on the RBD, some of them will not be on the RBD. Are binding antibodies from infections useful? All binding antibody from infection or from vaccine are useful because they activate the biological processes. Actually, binding antibodies are very, very important. it's not necessary that majority of our antibodies are neutralizing. Majority of them are binding, and they activate complement system, they activate the phagocytosis, they activate lots of other biological functions to allow this antigen to be destroyed and cleared away. Good question, though. Genesis Light says, when would be the best time to check vaccine antibody titer after the second dose? Checked my antibody after first shot and was 64 and curious about what the second shot would get me 2 weeks ago. So 2 weeks later is supposed to be full protection in majority of the vaccine. So that means 2 weeks later, you should have one of the highest peaks. So if you did a test, that will be interesting to see the result. Skyfrog says, I've taken melatonin for a long time, still have vivid dreams, but went from nightmare to boring dreams. That is interesting. So you know what is bothering me? What is that thing called when antibodies or complement coat a pathogen? So let's see. Give me 1 second. Oh, opsonization. Opsonization. So opsonization, although I did not find it in the Google, but meanwhile, opsonins are extracellular proteins that when bound to substance cells induce phagocytosis. So let me just very quickly, when so let's say this is a spike protein. I laugh at my own brain's behavior. I become totally blocked. So let's say this is an antigen, and then there is a antibody attached here. So now if you think about it, this is a spike protein. This antibody is binding and not neutralizing because it is not bound to the receptor binding domain. However, when it is bound here, and let's say another is bound here, this process of coating the antigen with these antibodies is called opsonization. And these antibodies and complement. So let me actually explain more. So this is called opsonization. However, before I explain what opsonization is, I'm still answering Soma's question. The bound antibodies open up a place on their constant region, which would allow the complement system to bind to the antibody. So when the complement system is activated because it is bound to the antibody now, then that complement system is going to start settling here as well, and activated complement system will be present near this antigen. One protein of the complement system is called C3, complement part 3 or protein 3. Complement 3 protein is broken up into C3A and C3B. A usually stands for active and B stands for binding. This C3B will also bind to this antigen. So now on this antigen, on this spike protein, we have lots of antibodies bound to there, and we have complement bound to it. That in turn causes, this process is called opsonization. The process of coating a spike protein or any antigen, any pathogen with antibodies and with complement. Now what happens is, I always, when I'm teaching my medical students, I always say, this is like, sugar coating the spike protein or pathogen. You put sugar on it. And the macrophages, they have a sweet tooth. They have a sweet tooth for the antibodies and for C3b. So when macrophage come around and they see this little coated thing, they say, oh man, I love this C3b. And they try to eat the C3b, and in that process, they'll eat this whole thing. Or if they find an antibody attached there, they will attach with the antibody to the Fc portion, and they will phagocytose the whole thing and destroy it. This is a normal, natural, important process. neutralizing antibodies' simple function is mechanically hindering the binding of the virus to the cell. Fine. But if it is neutralizing, what will happen to the pathogen now? We have to destroy the pathogen and clear it out. That can only be done when we have binding antibodies and complement system. So this was a rumor created by one of the anti-vaccine folks who said that, hey, somehow binding is worse than neutralizing. But binding is a very important part of the immune system. And that happens with the vaccine or the natural infection. So opsonization. And these molecules that are coating the, imagine a donut with the coated, sprinkles on it. These proteins are called opsonins. Okay, so Pasi is here. Hey, Pasi, how are you? So Judy says, are runaway spike proteins good for us? They're found everywhere. Is that problematic? So Judy, I think you're pointing at that Pfizer document from Japan that was used by many people to say that spike proteins go everywhere. That is not correct. That document is in Japanese. You can ask anyone who is Japanese, who can read it and is a little technical on medical side to decode it. They were not talking about the spike protein. They were talking about the broken pieces of lipid nanoparticle, not the whole pieces. Because I've talked with some of the folks who said, well, because lipid nanoparticle was in the ovaries, for example, then they say because lipid nanoparticle has messenger RNA in it, that means when lipid nanoparticle is found in the ovary, that will mean messenger RNA is found there as well. And I had done this discussion. That discussion got me so much heat. And that was, people did not like that I challenged this idea that these spike proteins are present everywhere. The lipid nanoparticle was supposed to be made up of 4 components. There were 2 components that we already know. And then there were 2 components of this lipid nanoparticle that were new substances used. And the researchers, which were asked by Pfizer, I believe, and it is totally fair on the Pfizer's part to do this, they were trying to figure out these broken pieces, these new components, what is their metabolism? We knew that cholesterol, how does that get metabolized in our body? They knew what messenger RNA would do. What they did not know was these 2 substances that they used to make lipid nanoparticle, A and B, they had specific code names. Where would they go? And what they found was that these substances, broken pieces, were found in various tissues. Now, it's very simple. Broken pieces, not the whole lipid nanoparticle was found. Let's say in ovary. An ovary would not care. It would just pick it up like it's a lipid and destroy it, just like it metabolizes other lipids, like cholesterol. They just wanted to understand, where does it go? How is it cleared? How long does it take to clear it? So, Judy, if your basis, the question is that somehow the lipid nanoparticle is carrying the vaccine everywhere, and that is what is bringing spikes everywhere, then that basis is incorrect. If you have some other study, then I need to look at that. Now, are there runaway spike proteins? That is still possible. And how is that possible? A possibility is that, let's say this is a cell. We introduced a vaccine. Vaccine is a lipid nanoparticle. That nanoparticle has messenger RNA. The nanoparticle is broken up here inside the cell. This is what they were trying to figure out, that these components of the nanoparticle, when they get out, where do they go? Nanoparticle components can get out because they're lipids. Lipid can cross the cell membrane. Messenger RNA cannot get out. If messenger RNA could get out, then why did we have to wrap it in a nanoparticle to bring it in? If we need something to bring it in, then we would need something to get it out as well. But the problem is when the nanoparticle enters the cell, it is broken up. When it is broken up, messenger RNA comes out. That messenger RNA would help make the spike protein. We've discussed it many times. Now imagine this. This cell has some spike proteins in it. And it is presenting pieces of spike protein on its surface. Then the cell gets destroyed by the immune cells. NK cell come around and they say, what the heck, this cell is presenting something I don't like, and they destroy it. That means some of these spike proteins can spill out. You can talk about them to say, where would they go? How dangerous can they be? And so on. Majority of the time, they are going to be picked up by the local immune system cells, macrophages, neutrophils, dendritic cells, and so on. Some of these will be carried by the macrophages to the lymph nodes, local lymph nodes. So some of this is going to end up in the lymph node as well. Some of this, because there is local inflammation, it is possible that some of these are going to just float away without being picked up into the blood vessel and end up in a blood vessel. But that's going to be a very tiny amount. So generally, I haven't yet seen any study that itself follows a spike protein to say it would go and cause damage. On top of this, what happened was how people made the whole thing muddied. The second part was, and I know the names of the folks who kind of created these rumors, there was a study, in vitro study, in which what they did was they took some cells. So let's say this is a cell. They took some cells and they poured spike proteins on them. So this is a cell and they put spike proteins on the cell. This was an in vitro study. This was inside the lab. The environment was specific. There were no immune cells nearby. And what they proved was, and correctly proved it, was that when spike protein attaches to an ACE2, just the spike protein, not the whole SARS-CoV-2, just the spike protein, when it attaches to ACE2, it causes secondary mechanisms to be triggered in the cell, which causes the cell to become more prone to inflammatory outcomes, and the cell is easier to be destroyed. Cell starts producing inflammatory markers, and cell's own some of internal functions get disrupted. Because of this, they said, hey, we think that the spike protein itself is cytotoxic. Without the SARS-CoV-2, just the spike protein is cytotoxic. And I agree with that. The question is, can we say this cytotoxicity in the similar environment? Do we have a similar environment in our body? In our body, around the cells are sitting macrophages, are sitting natural killer cells with the eye patches on them, are sitting dendritic cells, and so on. So when some cell is in trouble, they destroy that. When the spike protein is there, they're going to eat it up, they're going to clear it up. Now, let me continue to add thoughts to this one. So that means this was a good study to say spike protein itself can act as a cytotoxic thing. But this was not a good study to say this is what happens inside the body, because in the body, the dynamics are different. Then you saw that the latest studies by Bruce Patterson and by Paul Marik, correct? Their studies are that S1 part of the spike protein, S1 part of the spike protein itself is also damaging. And I presented that study last week where Dr. Paul Marik's team proved in mice that the S1, when just the S1 part, not the whole spike protein, what they did was they gave S1 part to some mice, complete spike protein to some other mice, saline to some other mice, and then S1 part to some mice which did not have human ACE2 on them. And they found that those mice that had humanized ACE2 receptors, genetically modified mice, and had S1 injected in them or given in them in their tracheal system, they developed acute lung injury. But those mice that had humanized ACE2 but were given complete spike protein did not develop the injury as severe as S1. So with this, they proved, at least in mice with the humanized ACE2, that it is the S1 alone that can cause acute lung injury. They had posed a question, what does it mean? They cannot make a conjecture yet. They can just demonstrate for the first time that S1 does participate in acute lung injury. So if I take this question, that is spike protein cytotoxic, I can take it one step further with Dr. Paul Marik's work to say not the spike protein, but this S1 part of the spike protein is even more toxic. One. Second, Dr. Bruce Patterson's research. He said, and I think we all know over here, that the monocytes are hanging on to the S1 part of the spike protein, which causes them to become immortal and keep releasing cytokines, which in turn causes long haul symptoms. So he's using, so that again is not the spike protein, it's the S1. And now he's using various medicines which are helping manage the long haul patients who may have S1 in them. So to answer your question, it's not just the spike protein. Actually, I was surprised with Dr. Paul Marik's research that the whole spike protein did not cause damage, S1 part did. Giladoni says, did you hear doctors not able to prescribe prophylaxis anymore? Was told by a doctor can no longer do it anymore, trying very hard. Yes. So not only that, folks are not filling prescriptions as well. So this is just a really, really strange situation. Silent Murmur says, I would hate to have a silent murmur. Your eye patch joke is hilarious. You have a great sense of humor, Dr. Thank you very much. And the silent murmur medical joke, if a student of mine had named himself angina pectoris, or the cardiac pain, and he or she, whoever they were, they sent me a message saying, I love you. And I said, no, I don't want angina pectoris. Gold Country says, gotta go. Good night. Good night. Texas is here. Texas, how are you? Sue says, also another study of spike on heart tissues. So we know any tissue that has ACE2, and when spike is attached to it in vitro, the spike causes the ACE2. There are two things it does to the ACE2. One is the ACE2 gets downregulated. This also was something, a person was very upset with me. And you can see the power of people who become upset, that they can go to various departments, they can complain about you, then the lawyers have to be involved, and the money and stress and time is involved. That's happening to me. So the person became very upset, and he said, don't you realize that when the spike protein attaches with the ACE2 downregulates? And there is an article about that as well. Interesting thing is the following. Imagine this is a cell and it has some receptor on it. Some receptor. ACE2, ACE1, insulin receptor, something else. Sodium, potassium channels, something. Receptors can be of many types. But an important thing is that in this context, There are some receptors when they are bound to their substrate or their ligand substrate, I'm saying. ACE2 is an enzyme, that is why I said substrate. Substrates are for enzymes and ligand are for receptors. So when it is bound to a ligand, some receptors are robust enough that the ligand binds here and then detaches or is destroyed, and the receptor becomes empty again and continues to function. Still, our body would recycle the receptors every so often because most of the time the receptors would not stay there forever and function correctly. So we just destroy them and recreate new ones. In case of ACE2, when you bind it with some ligand, most of the time the ligand would bind to this and it is broken up into two pieces. One piece is liberated, which is called, I believe, ACE1 to 7 or something. And in this process, this is possible that the ligand plus receptor, this whole complex, is internalized, phagocytosed, this whole complex, and then destroyed. This is a normal function. This would be called down. Down regulation is a little more than just picking up and destroying, but this is what happens. The receptor is brought back in. It is recycled because now this receptor is really not useful because it has this protein attached to it. So if we bring it in, we destroy them both, recycle their raw material to make more receptors, and then bring those receptors up. Down regulation simply means reduction in number of receptors. And down regulation could be intentional. For example, if you take a cell, for example, let's say nicotine receptors, you start smoking and there is too much nicotine entering our body, and there were, let's say, 1,000 receptors, and now they all have nicotine on them. And the cell says, man, I was only expecting 100 nicotines. Why are my 1,000 receptors all filled with nicotine? So you know what? I'm just going to reduce my 1,000 number down to 400. I don't want so much nicotine. So now this is called down regulation. When you stop nicotine or smoking, then what happens is all of a sudden the cell says, man, I wanted a specific amount of stimulation and there is no nicotine. So what I'm going to do is I'm going to make more receptor to try to catch more nicotine. And that is the process of withdrawals and those things. The point here is receptors are recycled all the time. It's not a news to say that when a receptor is functioning and it is bound to its ligand, somehow it would recycle. It recycles. It's a normal process. When it is brought down and destroyed, a new one would be brought up. Doug has a very good question. How long to wait after vitamin D dose change from the blood test? So, Doug, remember for myself, I had been taking 10 to 20,000 units for what, 2-3 months before it went from 19 to 29. So I think important thing to note is that it is body's usage. So one could get the test result tomorrow after taking vitamin D, for example. The question is, how much did my body use? How much of this went into storage? And then what is left that is being tested. So it is going to be different for everyone depending upon what is their starting point. Starting point, if it is low, that means their stores are low in quantity. That means their circulating vitamin D is low as well. So when you take vitamin D, or when somebody or me takes vitamin D, that if you test it again, it may not have made a lot of difference because it may have gone to storage. Or maybe if the body is under stress, let's say COVID or something else, and it is being used up very fast. So that means there is not a linear process to say, I take vitamin today and tomorrow my levels should be correct and I can test them. It would depend upon body state, body's usage of vitamin D and so on. I tested about a couple of months after. Good question. On the on the pharmacies and filling of the drugs, um, they refused to give me ivermectin. I couldn't get it. My doctor wrote a prescription, and they refused to give me ivermectin. My doctor meaning it's actually someone, a Cool Beans reference. So Alquin says, what are your thoughts on Australia becoming a police state after the sniffles? Australia never shut down fast food restaurants, even though they kill far more people each year. Alquin, seems like a sad thing. I have to read up more. I have deliberately kept myself um, away from the news because these are the kind of things I could not help, and because of that I stayed focused on what is it that I can do. Although nowadays, because of these legal things and all that, I have now gotten enough of other distractions that I should probably start reading news as well. So I would read up. It would be sad if they are not. It will be bad. Skyfrog says, are there any other drugs that you've been refused by a pharmacy when a doctor prescribes aside from interactions? No, at least not in my, aside from interaction. But normally, at least in the US, when somebody prescribes it, most of the time the computers can pick it up and kind of give a warning. MSNBC says, if Jane Doe, not a real person, was not vax, has ivermectin on hand, and plans to get monoclonals if gets infected, can Jane take ivermectin before monoclonal? Jane doesn't want to kill monoclonal effect. So let's look at the mechanism. And really, I was talking with Margaret today, and I was talking about Joe Rogan and how so many people hoped and wished that he had become severe. And I can understand that he is experiencing that, considering I am a tiny, tiny little fractional voice and I get so much of heat. A person who is so much more known and heard, I'm sure he has so much more haters as well. Where I thought he was, if I have not heard him, so I may be wrong, if he had said that your body's natural immunity is sufficient and you don't need a vaccine, then he was wrong there. That should not have been the case. Ivermectin's, vitamin D's, everything else, it's a good bridge to provide as much protection as we can towards a vaccine. But to say just don't take a vaccine. So I don't know if he said that or not. So those comments who said, hey, he said that his immune system is sufficient enough and now he's taking everything else, that was not right. I think if he said that, then that comment may be correct. But wishing someone to say, and I have gotten that as well, that people said, now you're going to die, and I'm anyways. For me, what is interesting is he had Regeneron as well. Trump had Regeneron. Giuliani had Regeneron. Regeneron works like magic. So I was talking with Margaret, and I was saying, I don't know why Regeneron is not made a standard therapy. I know that it is approved. I know that you can ask for it. It should have been just, you get sick, a person gets sick, Regeneron is the first thing to do. it is such an effective one. Yes, of course, take care of the allergies and the reactions, but it is polyclonal antibody. It is very, very effective, and it saves lives. So now question, antibody versus ivermectin. So here is an antibody floating around. Let's say we injected it from outside. This antibody has the binding sites to attach with the virus, correct? So virus may be present inside. This antibody may be attaching with the virus's spike protein. So let's say this is the virus. These are the spike proteins. It's a sad virus because its spike protein is now captured by an antibody. And it knows that now it is going to be phagocytosed and destroyed. Now let's say there is ivermectin here. Ivermectin's job, one, is to attach with some of the virus's spike protein. That is an in silico study. We have looked at that study in the past. So let's say it attaches with the spike protein. If that is the case, and there is sufficient amount of ivermectin to coat the spike proteins, and if that happens, then this binding could become less effective, right? Because ivermectin could hinder with this binding. So that is one. Now the second function of the ivermectin inside the cell, RDRP disruption, that has nothing to do with this one because there is no RDRP disruption with the monoclonal. So monoclonal's job is to coat the virus, opsonize it, prevent it from binding to the ACE2 receptors. This is acting like a fake receptor for the monoclonal, for the virus, plus to activate the biological phenomena of opsonization and coating of activation of C3b, phagocytosis, and so on. So clearing of the virus, mopping up of the virus, neutralizing of the virus. Now RDRP, if there is any virus inside, it would work with that, but it would not hinder with the monoclonal's function. 3-chymotrypsin-like protease disruption, again, if monoclonal is present, then ivermectin cannot do anything because it works on the 3-chymotrypsin-like protease, and if there is any virus in the cell, it might disrupt that. Then the virus's importin alpha and beta pathway, that also is inside the cell, is related to the virus, not here. So monoclonal would continue to work. Then is the nuclear factor kappa B or K beta. So nuclear factor K beta is the inflammatory pathway that ivermectin can modulate. That is another pathway that, let's say, when this complex of the antibody, let's say this antibody is hanging on to this virus, and then this whole thing is brought in, then the cell is going to create cytokines and chemokines and all that, which would then cause inflammation. This inflammation is partly useful and partly damaging. This inflammation is going to be modulated by ivermectin. This is a good thing, not a bad thing. This will be a bad thing if ivermectin hinders the virus's attachment to the antibody, and these things don't matter. So that is how, from a mechanism point of view, will happen. Or that is what, from a mechanism point of view, will happen. Nipa Gandhi says, did Trump ask for regen or not? How will a general public know what to ask, what not to? It makes no sense. So Nipa, this is exactly what I was actually talking about with Margaret, that let me see if I can actually look at, I'm going to bring it here. FDA Regeneron. If I go to coronavirus COVID-19 update, FDA authorizes monoclonal antibodies for the treatment today. So this was November 21, 2020. Today, EUA for casirivimab and imdivimab to administer. This is the Regeneron antibody. There are two antibodies actually together for the treatment of mild to moderate COVID-19 in adults and pediatric patients with positive results. So these are not authorized for patients who are hospitalized due to COVID-19 or require oxygen therapy due to COVID-19. So I think what they're trying to say is, if the patient is in viral stage, then these are useful because it would mop up the virus. If the patient is beyond the viral stage and now is in a cytokine storm, then these are not going to do anything. So the question is how to ask for them. So I think it is the doctor or the patient who have to request for it. So your question is correct. The thing that I was talking with, I'm sorry, you cannot find it. I was speaking with Margaret about that was as well, that this could have been a standard to say, if you suspect somebody in the viral state, just give them Regeneron and prevent them from becoming worse. Our patron says, I hear the duck quacking all the time. So Avox has asked me to buy a penguin mouse, so I will buy it. Till that time, please, my apologies. Whenever I move this mouse, I used to use this one, so it is silent. But after pressing this mouse for 1.5 years or 1 year, my finger developed arthritis and I had lots of pain. That pain is still there, but much less. And of course, you know that my shoulder and hand has issues as well after this continuous drawing and sitting like this. So because that mouse was giving me pain in my finger and my hand was getting numb, I used this. And so one bad outcome is that it has this mouse thing that makes a noise like a duck. Sorry. Lizzie says, where is Luffy? So Luffy, just before the discussion, he was upstairs. Haven't seen him down here. So how about we do this? We break for today and we will continue tomorrow. So thank you very much for your time and for being with me. Please like, subscribe, and share. And if you would like to support this work, there are 3 links in the description. You can be a patron, you can use PayPal, or you can buy me a coffee. Thank you very much. Stay safe, strong, happy, and healthy. And I would see you tomorrow. Bye-bye.